Of this section of Listen to Author, we are honored to share our work with the reader of Korean Journal of Radiology, which entitled With CT-based Leiden score outperforms confirmed score in predicting major adverse cardiovascular events for diabetic patients with suspected coronary artery disease. Scholars from the Chinese PRA General Hospital, led by Professor Yundai Chen, collaborated for this work. As to disclosure, the study was funded by National Key Research and Development Program of China and Medical Big Data Program of PRAGH. Diabetes represents a public health concern as it can predispose individuals to cardiovascular disease and promotes the risk of adverse cardiovascular events, such as myocardial infarction and stroke. The 2019 ESC guideline, as well as the 2020 ACC-AHA guideline, highlighted the importance of cardiovascular risk assessment for DM patients, and coronary computed tomography angiography was recommended as a first-line assessment. There are many kinds of CCTA-based scores in clinical practice. The calculation method and focus scope are diversified. It remains unknown which CT-based risk score is the most appropriate for patients with diabetes. Some scoring models, such as Leiden score as well as confirmed score, integrate multiple atherosclerosis characters, permitting comprehensive and systematic assessment. Specifically, Leiden score included all segments of coronary artery tree and dominant information. The confirmed score included clinical risk factors based on NCEP ATP 10 years risk. So, the present study aims to compare two CCTA-based risk score algorithms, including Leiden and confirmed scores, in patients with diabetes mellitus and suspected CAD. This study was designed as a single-center prospective observational cohort study. DM patients undergoing CCTA examination due to suspected CAD were consecutively enrolled. Of the 1643 DM patients with suspected CAD, those with early revascularization within 90 days after CCTA, uninterpretable CCTA imaging, incomplete clinical data for failure analysis, and patients lost to follow-up were excluded, leaving 1241 patients in the current analysis. In addition to standard clinical data, CT-based parameters including stenosis, CAD rise, plaque composition, and high-risk plaque were recorded. Leiden and confirmed score were calculated, and patients were stratified for low, mid, and high risk by the cutoff recommended in Leiden and confirmed score. Follow-up data were collected from electronic medical records or patient interviews for at least 90 days after the CCTA examination. The primary outcome of interest was major adverse cardiovascular events, defined as composite outcome of cardiovascular death, non-fatal myocardial infarction, stroke, and unstable angina requiring hospitalization. The final study population comprised 12 and 41 patients with a mean age of 60.2 plus or minus 10.4 years. The major cardiovascular risk factors were hypertension and hyperlipidemia. Information on cardiovascular agents at baseline was also recorded in the table. Diabetes treatment was categorized as diet-only, oral hypoglycemic agents, and insulin. In total, 131 MACE, including 17 cardiovascular deaths, 28 non-fatal myocardial infarction, 22 strokes, and 64 unstable angina requiring hospitalization occurred during a median follow-up duration of 31 months. For the Leiden score algorithm, the MACE rates was 1.8, 5.8, and 10.7 per 100% years in the low, mid, and high score groups, respectively. There was a similar trend in MACE rates stratified by the confirmed score algorithm, which showed 2.7, 4.2, and 7.7 per 100% years in the low, mid, and high score groups, respectively. In the univariable analysis, age, hyperlipidemia, and HRP were associated with MACE. Patients with higher Leiden or confirmed scores had a higher risk for MACE. In the multivariable analysis, Leiden score was still significantly associated with MACE after adjustment for age, sex, hyperlipidemia, smoking, and HRP. However, a weaker increase in the risk with increasing confirmed score was noted, although the results were not statistically significant. As to discriminatory ability of risk scores, the area under the curve for the discrimination of those who had and didn't have MACE was 0.84 for the Leiden score, which was significantly higher than 0.777 for the confirmed score. NCEP-ATP3 score didn't show incremental benefits over Leiden score in discriminatory ability. So, in summary, Leiden score and confirmed score were both significant predictors in DM patients with suspected CAD. CCTA-based Leiden score outperformed the confirmed score in predicting MACE for DM patients with suspected CAD. Leiden score could be a feasible solution in risk stratification of DM. Artificial intelligence technology will promisingly facilitate the CT-based risk score algorithm in the near future. As an extension to our discussion of DM in the presence of diffuse CAD and microcirculation, a global assessment of all coronary artery segments, such as the Leiden score, might be preferred. Global anatomy assessment for DM patients with diffuse CAD may be necessary in risk assessment. Finally, thank you for listening. For more information, please refer to our article.